Hi, and thank you all for joining us today for another CDAPP Sweet Success webinar covering the topic Medical Management of Type 1 Diabetes During Pregnancy. My name is Tracy Esquivel, and I'm the Project and Communications Manager here at Community Perinatal Network, and I'm also part of the CDAPP Sweet Success Resource and Training Center team. Before beginning our presentation, I would like to make some housekeeping announcements. Firstly, handouts for this presentation were sent out yesterday at 9 a.m. So if you registered for this event after that time, you can go ahead and check your GoToWebinar control panel. Under the handouts tab, you'll find both of those handouts there. If you have any problems with that, just email us at cdapp@perinatalnetwork.org. Next, please continually check your spam folder, as sometimes the handouts that I send in advance, as well as the webinar invitations and reminders about the upcoming webinar, are sent to that folder. Also, if you're watching today with a coworker or colleague and only one of you is logged into this webinar, we won't have record of both of you actually attending. We only have record of whoever is actually logged in. So if there's multiple people surrounding a computer or in a conference room, just let us know via email who all is in attendance so that we can give you credit that you have actually watched this presentation. So just send us an email at CDAPP as in Paul, P as in Paul, at perinatalnetwork.org, the same email that sent you the handouts for today's webinar. Next topic, the CEU process. This webinar ends at 2 p.m., or excuse me, at 1 p.m. Pacific Standard Time. So 1 hour after the end of the presentation, so at 2 p.m., everyone who we have record of logging into this webinar will receive an email from us. And in that email, there's directions of how to get a CEU certificate. It basically gives you a link that takes you to SurveyMonkey, which is the platform we use for our webinar evaluations. And upon completion of that webinar evaluation, we will email you your CEU certificate in about 2 to 3 weeks. So pay attention to that email that should come to you around 2 p.m. Pacific Standard Time. In that webinar evaluation, in question 1, please take your time answering that, as that is the information that we pull directly to your CEU certificate when we generate them. So try not to rush your name or credential or email, or else it might get lost or we might have the wrong information. Next, for all the CDAPP Sweet Success affiliates on the webinar today, I just wanted to thank you for turning in your forms, both your 2017 MOU and your annual affiliate survey for continued affiliation with our program. We're grateful for your hard work. I know that takes time and effort to turn in, and so I just wanted to thank you for all that hard work. And for the few of you who still have not turned those in or one of those forms, please contact our office, as there's probably an issue of staff turnover and maybe our communications are getting to the wrong person. So just contact us, because we're trying to contact you. Lastly, circling back to today's presentation, we'll hold a question and answer time at the end. So feel free to write your questions into us as they come to you, and we'll just save them for the end of the presentation and get to them as best as we can. Finally, I'd like to present to you our speaker, Dr. Kathleen Berkowitz. Dr. Berkowitz received a Master's of Science in Reproductive Endocrinology and went on to medical school at Jefferson Medical College in Philadelphia. Following medical school, Dr. Berkowitz completed an internship in obstetrics and gynecology at Columbia Presbyterian Medical Center in New York City. She also completed her residency at Columbia Presbyterian Medical Center in obstetrics and gynecology, and later her fellowship in maternal fetal medicine at the University of California, Irvine. Dr. Berkowitz is board certified in obstetrics and gynecology and maternal fetal medicine. She currently works at Long Beach Memorial as an obstetrician gynecologist and is affiliated with multiple hospitals in the area, including Presbyterian Intercommunity Hospital, where she is the director of the Perinatal Center. She has worked for Sweet Success for the state of California since 1994. Dr. Berkowitz, we're really glad to have you back to speak on type 1 diabetes during pregnancy. And whenever you're ready, the presentation floor is yours.
Hi, everybody. I want to thank you very much for allowing me to speak. I gave pretty much the same lecture, April of last year. For those of you who heard it last year, I'm hoping to throw in a couple new things, and really try and give you a very comprehensive sense of taking care of a type 1 diabetic from pre-pregnancy planning all the way through postpartum and breastfeeding. Here's the disclaimer and conflicts. I have no conflicts to disclose. And here's the objectives that we have for today's lecture. I really do want to emphasize optimizing pregnancy planning. And some of the other really important social issues I've seen, especially, are helping that type 1 teen transition to being an adult and having control over her own complicated medical condition and adjusting to those new glycemic control measures that we need for pre-pregnancy planning and for pregnancy control. That means for all patients also, we're assessing what our educational needs are about how pregnancy affects the insulin resistance parameters for especially the type 1 diabetics. And then I think this one probably doesn't get emphasized enough is the seamless reintegration back into her original healthcare team, or if she didn't actually have one, to create one for her. So those are the objectives we're going to talk about today. And then at the end, we'll be trying to leave lots of time for questions. So the first thing is convincing your patient that she actually has a medical condition that can cause complications. For a lot of people who've been type 1 diabetics for a relatively short period of time, maybe their teens until their mid-20s, they haven't necessarily seen the effects of diabetes on their end organs. And so pregnancy may be the biggest hurdle that they've initially facing in figuring out that, yeah, their medical condition can actually cause some complications. So our goals, of course, are a healthy mom and a healthy baby. I always tell everybody that our goal is to get mom and baby out of the hospital together, breastfeeding. So no preterm delivery, no preeclampsia, no neonatal jaundice. Those are what our goals are. So we'll talk about the maternity goals, prevention of the complications, and this is also a time when you have a unique opportunity to talk to her about what the long-term medical complications can be. We want, of course, a baby to be born at term, not early. We don't want anything like shoulder dystocias or brachial plexus injuries. And we do want to at least begin that conversation about long-term medical complications that might be caused because of anything that happened right around the timing of birth or during the pregnancy itself. So from a maternal point of view, especially with the type 1s, they need to understand that the incidence of miscarriage is increased if you have poor glycemic control at the time of conception. You're also going to be in an increased risk for urinary tract infections, especially in the early 3rd trimester. That can kick off things like preterm labor or even a diagnosis of acute respiratory distress syndrome in some cases. You're a little more likely to get preeclampsia, also known as toxemia, and your cesarean section rate is going to be a little bit higher because if you need to be induced for those complications, your section rate is going to be higher. From a baby's point of view, the malformation risks are a big thing to discuss. Stillbirth is probably sort of the biggest fear for many women, but it is actually not as common as you would think it would be. Birth trauma is actually a bigger issue, and neonatal metabolic complications, we'll talk about those as well. So what can we do to decrease the risk of complications? Well, first thing is recognize what stage of disease you're at. Do you have chronic hypertension? What's your body mass index? What medications are you on? What other things are going on with your kidneys or your eyes, your heart or your liver? I think that's a really important baseline to establish for all type 1 patients. The next is you got to have a team approach. Over at Presbyterian or Community Hospital, I'm really lucky because my office is situated literally right between one of my biggest referrers and my Sweet Success team of diabetes nurse educators. And so it's fairly seamless for patients to just walk through one office to my office to there. It's easy for them to walk over to me and say, hey, did you know so-and-so's not doing this with diet? So it's a really seamless team approach. I don't have that same situation in some of my other offices. And so then patients have to travel and work a little harder at achieving that. Diet, exercise, and home glucose monitoring are the mainstays. We work insulin therapy around stabilizing those issues first. Again, for type 1s, you're only going to be using insulin. Your oral agents are just not going to be appropriate for the type 1s. But it is important to see what other oral medications she might be on. Recognition of why we want the goals that we want for glucose control. And then again, if you can use this time to raise her awareness for long-term health risks and come up with strategies to help her stay healthier or with a better hemoglobin A1C, yeah, that's bonus points. And that's very important to do as well. Okay, so when I'm lucky enough to get someone who's a type 1 diabetic who is planning pregnancy, I love to be able to sit down with them and talk to them about what goals to achieve. One of the things that you have to realize is that planning for pregnancy means also planning not to be pregnant until you've met those goals. If someone is coming in for a pre-pregnancy evaluation, we're going to look at her baseline medical status, her medications, achieve glycemic control, and we'll talk a bit about that in just a minute. Get her pregnant, and then get that team approach going right away. Now, let me talk about how hard it is to get a seamless approach going here. This example slide is from 2008, but I literally had the same one 2 months ago. This is a patient, you can see July 25th. She had a diagnosis of class B diabetes that hadn't been recorded well in her prenatal intake. And so somebody did a 1-hour PG, and it was 411. And so the doctor ordered a 3-hour GTT. I am not joking on this, and you can see that on 2 weeks later, she had a 3-hour GTT, 219, 410, 397, 309. I did not get to see this patient in consultation until the end of September, beginning of October, and her due date was in the middle of November. I love to say that that's an unusual thing, and unfortunately, it's not, because our healthcare system is still fairly fragmented, and there are often delays. And averages that I'm seeing are from a time a patient is recognized as having a medical complication to the time I'm seeing them in consult, usually 4 to even 6 weeks. Sometimes it's quicker, but not always. And that's important because over 50% of the pregnancies in the U.S. are not planned. That doesn't mean that they're not wanted. It's just nobody was planning for them. And because some of the miscarriage and malformation rates happen so early, they happen even before a lot of people realize that they're pregnant. So if you've got poor glycemic control in that preconceptual period, you're going to have an increased risk for a miscarriage or a malformation. So one of the conversations that should be happening with their primary care doc is they need to either be planning to be pregnant or planning not to be pregnant. If you're not planning not to be pregnant, then you're going to get pregnant. Contraception options are pretty varied. Some of them do get circumscribed depending on what your coexisting medical complications are, and we're going to go over that pretty soon here. So one of the things that is a very good option is an IUD. There are progesterone ones, there are copper ones. There is a historical reluctance in the obstetric community to use them for patients who have not had a baby before because of the risk of pelvic inflammatory disease, but at least the copper IUD has not been associated with an increased risk for that. Everybody's worried about BMI. Birth control pill does not increase your BMI despite everybody's thought that it does. If you look at women who are on the pill as new users and those who aren't, both groups will gain about 5 pounds in that first year. It is true that some of the more sensitive type 1s might see some blood glucose fluctuations based on what their menstrual cycle is, and that's especially true with a lot of our pump users. So they'll see changes in their insulin resistance based on what goes on with their period. And so those things can change if you're put on a combination pill. Pills, patches, rings, they're all okay to use. I just got back from Honduras, and the LARCs, the long-acting reversible contraceptives, are enjoying a huge popularity there in that area where they just don't have a whole lot in the way of access to medical care. So Depo-Provera, Mirena, Copper T, Implanon are very good methods to consider for someone who doesn't want to be pregnant for a while. From what's recommended from the CDC, any method is okay in a diabetic woman who doesn't have vascular disease. If she's got vascular disease or she's a class D, duration greater than 20 years, then you'd probably try and choose one of the LARC methods rather than one of the combined pills. Okay, here is why pre-pregnancy planning and contraception is so important. Take a look over on the right-hand side at the gestational age of occurrence of some of the sort of classic congenital malformations we see common to infants of diabetic BOM. So caudal regression syndrome, very rare in the general population. 1 in 350, still fairly rare in the type 1 population, but it occurs at 3 weeks gestational age. Neural tube defects increased in the type 1 diabetic population with poor control. That's occurring at 4 to 6 weeks. Cardiac defects at 5 to 6 weeks. Renal agenesis at 6 to 8 weeks. A lot of people don't even figure out they're pregnant until around 5 or 6 weeks. And so at that point, changing your glucose controls will not change your risks for those things to happen. So that's why it's really important to plan. Another slide showing why it's really important to plan. Preconception control group versus the quote-unquote late entry group, which was 6 to 8 weeks. And the non-diabetic population, risks for malformations are listed there on the right-hand side. So you can see, at least in that study, and this is obviously not new data, this goes back to 1983, and there have been several studies since then showing the same thing, that if a diabetic patient receives preconception control, her risk for a fetus with malformation is actually lower than the non-diabetic population compared to that late entry group where it's 7-8%. And the risk in the general population there is like 2 to 3%. So that's what is really, really important to recognize is how important that early care is. Again, here's a couple of more studies. Steele's got one, Kitzmiller's got one, Mills has a huge one. They have all shown over and over again that preconception care decreases the risk for miscarriage and decreases the risk for malformations. If you don't know hemoglobin A1C, what do? Well, we've got the same data based on fasting sugars. And so notice that if your fastings are 120, then that's where your risk is already starting to significantly increase. So that taller, darker orange column there is miscarriage rate, and that is already, even if your fastings are in the 120s, in the 25 to 30% range. If your fastings are greater than 140, then you're 30+% on miscarriage rate, and somewhere around closing in on 8 to 10% for malformation rate. And again, most of those are early malformation. So we'd like to prevent all this stuff. Preconception counseling goals are to get your hemoglobin A1C under 7% prior to conception. Take a look and see what medication she's on. ACE inhibitors, for example, they're not a big deal in the first trimester, but if you're on them in the second trimester, they will kill fetal kidneys, and you'll have renal failure, which is non-reversible. So it's important to make sure that early pregnancy is recognized, even if preconception planning isn't isn't being practiced. Statins, again, anybody who's sexually active and has a medical complication not using contraception, we've got some issues that we'll have to deal with when the pregnancy occurs. A baseline eye exam in the first trimester, depending on what level of retinopathy the type 1 diabetic has, you may need to do it each trimester if she's got background retinopathy or proliferative. If she doesn't have that, then things are a little bit easier to deal with. Lots of research, folic acid supplementation may decrease the risk for neural tube defects. You need at least 600. And for those who don't know, that's really one of the big differences between a prenatal vitamin and a regular old general vitamin. Prenatal vitamins are going to have at least 800 micrograms to even a milligram of folic acid in them compared to the general vitamin, which is usually got like 400. So folic acid supplementation should start at the same time you start working on preconception control. Then the next thing is to figure out what classification she's at, because classification equals complication rates, with Class B and Class C diabetics having fewer complications than the ones that you'll see listed down there with D, F, R, or H. Notice that a Class D is either very early age onset or over 20 years duration, or somebody has microalbuminuria or a background retinopathy, regardless of the age of onset or the duration of disease. Same thing with Class F, it's an R is an H. It's whenever you get these complications of nephropathy, retinopathy, or heart attack, that's when the risks for pregnancy begin to increase. So from a point of view of the Class R or retinopathy patients, if she doesn't have any retinopathy at baseline, again, the development of proliferative retinopathy is pretty rare in pregnancy. One thing that'll happen is if you don't have a patient who's had an eye exam and she does happen to have proliferative retinopathy, if you go for quick normalization of glycemic control in that first trimester, you may actually make that proliferative eye disease a little bit worse for that subset of patients. Blood pressure control, pretty important. If you don't have good blood pressure control or good glycemic control, your retinopathy is more likely to progress. Laser therapy is absolutely fine and normal in pregnancy. Trying to get a laser eye surgeon and an eye referral for some of my Medi-Cal patients is very difficult, but there is nothing wrong with having laser surgery during pregnancy. It's doable. It is not contraindicated. All right. The renal disease patients are the group that probably you'll see most frequently for the type 1s, and they are the ones who really do have increased risks for pregnancy complications. So nephropathy is anything over 400 milligrams of proteinuria in 24 hours or a reduced creatinine clearance. Most people, normal proteinuria that we spill is somewhere around 150 milligrams. If our BMI is really up there, then you might be in the 200 milligram range, but that should be normal. Serum creatinine should be normal. Serum creatinine of 1.4 is essentially double what would be normal in pregnancy. And if you hit that threshold, 5% of fetuses will die before delivery. 60% will have preterm delivery, compared to 8 to 10% in the normal population. 40% will be growth restricted. If you start a pregnancy on dialysis, even with really intensive management, about 50% of those pregnancies will end in a fetal demise prior to delivery. And about 90% of them will end up needing an indicated preterm delivery, usually because of growth restriction. And dialyzing in pregnancy is it's doable, but it really requires some very tight stepwise team approaches to doing that, because you have to do it more frequently and you have to be very careful about how you pull fluid off, because if you do your dialysis too quickly, you could increase the risk for a preterm delivery. Of those patients with nephropathy, lots of them will have transient worsening of their renal function. Usually goes back to baseline by around 6 weeks out. And as long as your serum creatinine is less than 2.5, you're probably not going to end up on dialysis. But again, we use ACEs and ARBs very commonly to protect renal function in the type 1 diabetics. That is contraindicated in pregnancy. You're going to have to switch to a different agent. There is a little bit of data that says calcium channel blockers might give you some protection, but you can't use the ACEs and you can't use the ARBs. Unusual situations, we don't see that many with coronary artery disease, but those maternal mortality rates are around 50%. You can sort of stratify them by if a patient had her MI and recovered and then got pregnant at least 6 months after her heart attack, her mortality rate is going to be lower than someone who has an MI during pregnancy. And so, again, chronic hypertensives, if they've been a long-standing chronic hypertensive, you need to treat them. Beta blockers, calcium channel blockers, the internal medicine guys laugh at us for using methyl-dopa because it doesn't usually work well outside of pregnancy, but it does tend to work very well during pregnancy, and so you'll see a lot of patients on that. So when someone comes to me for first visit, these are the risk assessments that we're doing for someone who wants to get pregnant. What's her class of diabetes? And then you have to remember the same stuff that you do for all the other pregnant ladies. You know, what's her obstetric history? Does she have a history of preterm deliveries? What's her family pedigree? Is there a family history of an autosomal recessive disease? What medications is she on, and what do we need to switch her to? Does she smoke? Does she use alcohol? And again, what's her glycemic control? I'll throw another one in there right now, which is don't travel to Zika areas, but that's a different lecture entirely. So this is the lab studies that I will be ordering for someone who wants to get pregnant. Again, type 1s, you don't see this quite as often, but you do, as you do with the type 2s with their syndrome X. But you will see thyroid dysfunction, and if thyroid is not working well, it's really hard to obtain good glycemic control. Lipid panel just as a baseline and a hemoglobin A1C. Again, dilated eye exam is recommended every year, should be performed before you kick off the decision to get pregnant. Are you hypertensive? Let's get some baseline studies on how well your kidneys are working. If you've got other issues like BMI or hypertension, an EKG as a baseline is a really good idea, looking for those risk factors for congestive heart disease. And then go over what her schedule is so that you can work your therapy into her schedule. The more that you can work your therapy into her schedule, the more likely you are to have a patient who's happy to maintain that. If you start trying to mess her schedule up and it messes up her school or her work or her family commitments, you're going to have a much more difficult situation to deal with. And then figure out where is your patient at in her ability to sort of actively participate and manage this intensified regimen. Is she ready for this? Some are, some aren't. Pull your team together. At a minimum, you need a diabetes nurse educator, a nutritionist, an experienced healthcare provider to work with, either your OBGYN or whatever, or your MFM. Coordination with whoever her primary care MD. It might be an endocrinologist, it might be an internist or a family medicine doc, but it's usually someone that the patient has developed a therapeutic relationship with, and you don't want to get into a situation where you're telling her something that the doc that she's been seeing for the last 10 years doesn't agree with. So your whole team needs to get in on what the goals are together and how to reach them. Everybody needs diet, which is 3 meals and 3 snacks, a low level of exercise, which if you can get them to do some walking or aerobic exercise after eating, that's best. And then home glucose monitoring. Again, for our patients on a pump, a lot of them do have the opportunity to have sensors, and so you may be dealing with sensors as well. The biggest issue I've seen with the type 1s is that they tend to do a look back rather than a plan ahead. So if they had a 200, a lot of them will skip a meal and give themselves some extra insulin. And then they'll be surprised when 4 or 6 hours later, they're at 40. That's because they are not looking back and using that information about what their activity or diet was to inform how they need to deal with the next 6 to 12 hours. And so getting them to plan ahead to avoid hypo and hyperglycemia is a big issue. And that's one of the reasons I really am not a fan of using the longer acting insulins in pregnancy, because I do see patients tend to get either an inadequate level of control or hypoglycemia because they're just not variable enough. I tend to, for my type 1s who are not on a pump, I like using the shorter acting insulins before meals and say an NPH at bedtime. And that helps them plan in 6 to 12 hour cycles and helps them with that planning ahead bit. Insulin pump management, I know that this time last year there had been an insulin pump management lecture just a couple months before mine. And so you might still have something that says that it was related to a February lecture. I'm not sure that that happened this year, but insulin pump management is truly just a whole different lecture. And if we have questions on it, I'll see if we can answer those at the end. So glycemic control goals are the next thing I go over with my patient. Because what's normal in pregnancy is way different than what's normal when you're not pregnant. This is a study looking at patients with lean BMIs. Normal mean glucose was 71 to 78. Normal fastings in pregnancy, 56 to 60. Normal 1 hour after meals, and that's in lean patients. In patients that have higher BMIs, your normal fasting range is 60 to 90. Your normal 1 hour post meals is about the same. And so those numbers are much lower than most of our type 1s are used to trying to achieve. So the other thing you have to do is you have to come up with an agreement among your team as to what goals you're using and why. And you have to have a rational explanation for your patient for why they need to get to these numbers, what the consequences would be if they don't. So these are the 2008 ADA consensus panel statements. Hemoglobin A1C less than 6, mean daily glucose less than 110, pre-meals 60 to 100, after meals 100 to 129, overnights avoiding hypoglycemia. I think those are actually really good goals, and the data that is out there for pregnancy management shows pretty good literature saying that that minimizes the risk for maternal and fetal complications. But you guys will read 8 million studies. I say the less well-proved something is, the more studies you'll have trying to prove someone's point of view. And there's no dearth of studies looking at what is optimal glycemic control. I tend to simplify it. There's 3 categories. There's patients that fall into a category whose fastings and post-meal values are in a range where the majority of studies show low complication rates. There's patients that everybody agrees their values are consistently in a range where complication rates are increased. And then there's that group in the battleground where some studies show some benefit, others don't show much benefit. And so that's that battleground group. Looking at the HAPO study, rates of complication increase in a continuous fashion. There is no cut point at which you can say, this is good and this is bad. So you're left with a need for your team to define what your goals need to be. Again, based on the HAPO stuff and some of the other studies, I tend to go for pretty much the goals that are listed on the ADA 2008 guideline. I want to see fastings consistently less than 95. I want after meals consistently under 130. And the type 1s do need to be checking post meals. We'll go over why in a minute. And you have to, as a team, come up with the same thing, because otherwise the patient's going to get confused if she walks into your nutritionist and those goals are different than her endocrinologist and her obstetricians and her MFM specialist. It frustrates the patient unless she hears the same message. Okay, So now you've gotten her pregnant, got good glucose control, got her pregnant. She's dealing with fatigue, and she's beginning to see a lot of increased glucose variability. Very common problem for someone with type 1 diabetes. Insulin sensitivity is actually pretty common at 10 to 14 weeks. And because you are sensitive to it and you're not able to eat because you're nauseous, that's when you're going to see a lot of hypoglycemia. Luckily, hyperemesis is usually gone by around 12 to 14 weeks. So I'm a little bit cautious about making any big increases in insulin administration in that first trimester because of that hypoglycemia issue. Viability, should be able to see a fetal heart rate by around 6 to 7 weeks, and then you know that you're a go. Again, you've been working really hard on getting under glucose control. Now you're in that first trimester. She needs to know that she has an increased risk for symptomatic hypoglycemia. Up to even 40% of women will have that. And of course, if you're driving when that happens, it's a very unpleasant thing. So again, this harks back to why I like the short-acting insulins. I don't like the longer-acting insulins, especially in the first trimester. Make sure that somebody knows how to use glucagon. Train the family members to assist for severe episodes of symptomatic hypoglycemia. Go over the simple stuff with her. What have you got in your purse that says who your doctor is and what your medical complications are? Do you have a bracelet? Do you have a necklace? Do you have a tattoo? And yes, I actually have a patient. Don't know if I'd seen her for this lecture last time or not, but her mother was so frustrated by the fact that she had all these hypoglycemic episodes that she literally took her 16-year-old to a tattoo parlor and had type 1 diabetes tattooed on her arm. Not many patients go that far, but again, I've actually seen this. Remember, cell phones, nice places to have contact information, but if it's a password-protected device, the EMT is not going to be able to know what your password is. So you got to have something actually written, not just on your cell phone. Lots of patients have lots of different attitudes towards identifying themselves, even to healthcare providers, much less to the general public, as someone with type 1 diabetes. This was a forum from the UK from a patient who was very firm about the fact that she's got good control, she's got a good support system, and she does not want to wear anything that medically identifies her. Again, that is a very understandable point of view, but if someone finds you down, you really do want them to be able to quickly give you the support you need, whether it's glucose or glucagon, or evaluation, especially if you're pregnant. So I'm a big advocate of, even if you're not having a wearable medical identification thing, have something on your person at all times saying what your medical complications are and who to contact if you're down. Okay, getting out of the first trimester, now we're getting into the second trimester. One of the conversations you have to have with patients who've had an elevated hemoglobin A1C is that you just can't see these anomalies at 10, 12, or 14 weeks. You really are going to have to wait till the second trimester to screen for these, whether you're using a serum screening protocol like we have here in California with looking for neural tube defects, or whether you're going to use an ultrasound. You need to talk to them about how their work-life pregnancy balance is changing, how their psychosocial needs are changing, because there's a big component of anxiety that starts to appear for most patients in the second trimester, especially if it's their first pregnancy. The other thing that's very frustrating is, and this is especially true for the type 1s on a pump who are used to good control, they know what works. They know if they look at a plate and there's 45 grams of carbs, they know what their carb-insulin ratio is. And the problem with pregnancy is that changes. There are very big changes in insulin resistance based on the placental hormones that are being produced. And so what worked last week doesn't work this week. Very frustrating for a patient who had good control and now her body's changing on her. Here's the things that we can use for ultrasound for identification of anomalies. In the first trimester, a thickened T has been associated with an increased risk for fetal cardiac anomalies. We also use it for looking for chromosome problems, but it can be used in the diabetic population to help see who is the highest risk. Yes, you can have a fetal congenital cardiac anomaly and have a normal nuchal translucency, so it's not foolproof, but at least will show who really needs the most attention paid to this. One of the things you need to let your patients know about is they're not alone in this. The general population has a 1 to 3% risk for major anomalies. Minor anomalies, 3 to 5% of the population. We can see a lot of the major anomalies around 20 weeks, but we can't see anything, and we can't see everything. I had a patient last year, had a hemoglobin A1C at conception of somewhere between 13 and 14%. Everything looked fine, everything looked fine, everything looked fine, everything looked fine. Kid's born, the middle ear is not developed, the kid can't hear. That is a major anomaly, but it was never one that I was going to be able to find on ultrasound. So you need to let them know you can look for some things, but you're not necessarily going to find everything. Depending on how well trained you are and how well you can visualize the structures and what the specific anomaly is, you're going to be able to detect somewhere between 14 and 60% of the major anomalies. I always tell my patients, look for someone who either follows the American Radiology Association guidelines or the American Institute of Ultrasound and Medicine guidelines. And if they can show you certification in fetal echo training for their unit, that's probably a unit that's got some expertise. And a lot of places do have that. So patients should be informed on how they can figure out what kind of care they're getting. And they should know we've still got limits, even in situations where you do your best and get good visualization. You're not going to see microcephaly until middle of the late third trimester. You won't see growth restriction at 20 weeks for most cases. Brain functions, brain growth continues all the way to the age of 2. You're not going to find all brain abnormalities and things like corpus callosum. You're not going to see that either. Renal anomalies also usually don't show up until third trimester. So you may need to look later as well. There's serum screening. It'll show increased risks for neural tube defects and gastroschisis, cleft lip and palate. One thing that's important is that cell-free fetal DNA testing that is becoming so prevalent does not identify any of those risks. You would still need to do some second trimester serum screening. And in the state of California, that's the California Prenatal Serum Screen Program. Combination of all of those tests, you'll find most of the major stuff. And as for that work-life pregnancy stuff, this is where treatment fatigue sets in. Patients have been working really hard to get good glucose control during pregnancy, or they've been listening to us complain at them about them not doing that for months, and they're sore, and the insurance is not covering everything. But this is actually where things get harder, not easier. So you really need to have a discussion with her about when and where she can loosen up a little bit. 4th of July barbecues, cheating strategies, need to continue frequent glucose testing for the pump patients, sensors. And you need to inform her before it happens about the fact that the insulin resistance is going to significantly increase. Otherwise, she's going to cut back on her nutrition because she's mad at her numbers. And it's not a nutrition thing, it's a need for more insulin. Here's how this happens. Again, we already talked about 10 to 14 weeks, you got increased insulin sensitivity. And 14 to 18 weeks, things are fairly stable. 20 to 24 weeks, huge increases. I've seen patients who are on 10 to 20 units of insulin prior to pregnancy who will need 200 to 300 units by the time of the third trimester. So those carb-insulin ratios are going to change a lot, and that's why you need to check your after-meal sugars. Pre-meals will not give you this information. Poor glycemic control, especially around late second, early third trimester, is really going to affect fetal growth rates. and the risks for macrosomia. Here's some data showing you why postprandial glucose monitoring is so important. This was a gestational diabetic population, but you can see that the risks for things like shoulder dystocia, neonatal hypoglycemia risks, birth weight, everything is much improved in the patients who were managed with good glucose control and postprandial monitoring. A lot of patients, they'll double and even triple their insulin daily needs. And that means for the pump patients, they're doubling and tripling the reservoirs that they need. So these are huge increases, especially around 24 to 28 weeks. And again, pre-meal values are not going to help you find this. If you start seeing a lot of post-meal variability, that's usually because the insulin resistance is going up. Try and take care of it first with diet modifications. If that doesn't work, then you're going to change your carb-insulin ratios or your short-acting insulin doses. And again, make your counseling here very non-judgmental. This is hard. She was under good control, perhaps, and now she's not, and she's frustrated. Let her know you're working with her, and don't let her feel that she's unsupported at this stage. It is extremely important that you support your patients at this stage so they'll trust you and continue to try and work with you to get to those good outcomes. You know, most patients are really, really trying. Those that aren't usually have some fear issues or some understanding issues or some frustration issues that a lot of non-judgmental counseling will help you with. Now, special population. When do you put her in the hospital? Well, if you think she's got DKA, she needs to be in the hospital. If she's got a GI flu and she's unable to eat or drink and she's getting ketotic, she needs to be in the hospital. If she has an immediate need to start insulin and she can't do that in the outpatient setting, she needs to be in the hospital. But once you get in there, it's really hard to get out. And some of the hospitalizations I've seen are 5, 10, 15 days for glucose control. Shouldn't need to be that. You don't need to hit every single goal for good glycemic control prior to during the admission. But there are a few things that the team needs to put into place. Everybody should have a good understanding of diet, exercise, home glucose monitoring, how to administer insulin. Everybody should have outpatient access to this, and before she's discharged, she's got to have all of her supplies. Those are bases. So this is what my goals are for discharging a patient who's been admitted for rule-out DKA or for glucose control. Does she have a home meter, and does she know how to use it? Can she draw up and self-inject? Has she gotten dietary advice? Most importantly, does she know how to recognize and treat hypoglycemia? And then, as long as her fastings are under 140 and her post-meals are under 200, I've got a situation here where I can see her and let her communicate with me 24/7 after discharge, and I can see her within a week. And then we can fine-tune everything. So those are my goals for getting somebody out of the hospital. And generally, we can achieve those goals in 2 to maybe 3 days. All right. Now you've gotten through that. Now you're in the 3rd trimester. You're worried about infections and urinary tract infections. Again, the DKA risks we just talked about. We'll talk in a minute about stillbirth rates, preeclampsia, preterm labor, and then a little bit of the later stuff. Patients who are ill, and especially type 1s, are at a higher risk for DKA. Ironically, they often feel that they don't want to see their healthcare providers because they're too sick. They need to call you because if you're too ill to eat, you're too ill to be an outpatient. Urinary tract infections are things that you really have to look for. And treating those things early can prevent DKA, prevent stillbirth. Everybody who's pregnant and diabetic should have a flu shot annually. Treating DKA, very intensive management strategies. I've got this listed here from the ACOG practice bulletin. It's not that hard to do, but it is very, very time intensive. You got to be looking at things every 1 to 2 hours. Again, stillbirth rate, everybody is worried about this. Yes, as you move up the stage from type 2s to type 1s, your stillbirth rates are a little bit higher, but it is not something that the majority of patients with diabetes are going to be experiencing. We react to that risk, though, by doing twice-weekly antepartum testing, usually starting at 32 to 34 weeks, looking at the baby's heart rate and looking at that amniotic fluid index. Lots of ancillary studies not needed for routine surveillance. But if you look at a patient with type 1 diabetes who's well controlled, the risk for stillbirth is not much higher than the general population, okay? And some of those are babies that have got congenital anomalies. So I never try and threaten a patient with, you're going to kill your baby if you don't get good glucose control. But a lot of patients have had that and are very resistant to hearing that scary sort of an approach. So I'm never going to start with that risk. Preterm labor is a big deal. We have lots of ways of figuring out who is actually just having a few contractions and not likely to have a preterm delivery, the fetal fibronectin and the cervical length exams. The most common reason for preterm labor is an associated infection, so you look for those things. If you give a patient betamethasone because you do think that they're at risk for delivering within the next 48 hours to 2 weeks, you have to know that that will give you big increases in insulin resistance starting from 1 to 5 days after administration up to around 3 to 7 days out. And so you're going to need to have frequent contact with her and change her baseline. There are even some situations where you can have a team trained, an inpatient team in obstetric glucose management, use an insulin drip. I'm actually finding a lot of those teams are getting broken up these days. We had one at Long Beach Memorial, and unfortunately it was a victim of the most recent budget cuts. So we're no longer having that option for the number of patients we've used it for in the past. You may be finding the same thing in your hospitals. Preeclampsia rates are higher. Again, this is U.S. Preventative Task Force recommendations. Basically, any patient who has type 1 diabetes and a BMI issue or a chronic hypertension issue, using low-dose aspirin will slightly decrease their risk, and that should be started by around 16 weeks of pregnancy. Optimal timing of delivery, again, everybody's worried about a stillbirth. It is very low in a well-controlled type 1 diabetic. But for most patients, somewhere between 39 and 40 weeks is ideal. If you've got vascular complications, an early term delivery is something you can consider. Poorly controlled diabetics, they're usually going to have complications that'll help you individualize the management. They'll have preeclampsia or something else going on. As for route of delivery, you got to have a really elevated estimated fetal weight. 4,500 grams is 10 pounds. And if your patient is in that group, then cesarean delivery is recommended. Ultrasound, however, is not a very good way of figuring out what birth weight's going to be. And it is not a good way of figuring out which patients are at risk for shoulder dystocia. So if your estimated fetal weight is 10 pounds or more, you still have to do at least 330 C-sections to prevent one case of a permanent neurologic injury due to a shoulder dystocia. In the time that you do those 330 cesarean sections, you're going to have some collateral maternal injuries. So this is a conversation you have to have with your patients. Ultrasound, again, not an accurate estimate. An ultrasound report has got a 10 to a 15% error range, meaning if I say the estimated fetal weight by ultrasound is 4,000 grams, what I'm really saying is that estimated fetal weight could be anywhere from 3,400 to 4,600 grams. It's just not that accurate. People have looked at 8 million ways of trying to figure out what other ways of making ultrasound better. Doesn't work. ACOG does not recommend using it as a screening tool unless that estimated fetal weight is over 4,500 grams. Now, during labor, it's like exercise. Your insulin needs drop significantly. So whenever I can, I schedule them for the morning, and I let them eat and ambulate during those early phases of labor so that they don't get ketotic. The hospitals have horrible, big, thick things to stick your fingers with, so I'm fine with her using her own meter, which might use a smaller amount. Keep her hydrated. Got to be assessing glucose levels every 2 to 4 hours. And again, short-acting insulin is what you need when you need it. Do not make your pump patients try and manage their own pumps during labor. They're in pain. They don't know how these insulin sensitivity changes are going to happen. Don't make her do that. Do that for her. Ideally, you want glucose somewhere between 80 and 110 because you don't want the kid to end up with hypoglycemia. Again, checking glucose levels frequently. If it's less than 100, you're just going to keep D5 half normal going. You don't need to give any insulin. If it's over 120, you can either do a drip or boluses. Again, it depends on what your local resources are. Know that for B, C, and D diabetics, most hospitals will require an ICU admit because a lot of them don't have transitional nurseries. So even if your patient has done everything perfectly, she still needs to understand that the NICU may be taking her baby away from her, and that may interfere with her ability to breastfeed right after delivery. So that hurdle, you need to look at what your local resources are. Prolonged inductions, I'm not a big fan of because they have high failure rates, and using a day or two of Pitocin will increase the neonatal jaundice rates. Again, frequent monitoring of blood sugars, adequate hydration, those are the keys. Once you get her delivered and that placenta is out, her insulin sensitivity will almost immediately significantly increase. Resistance goes down. And in breastfeeding, we now worry about her getting hypoglycemic and dropping her baby as opposed to the tight control that we had. So that's the 4th trimester, and that needs to be explained to your patient, and she needs really a good transition, especially for that first week or 2 after delivery when she's breastfeeding, because of those changes in insulin sensitivity. I've even had some patients who don't need any insulin at all for a week or so. And then you help her in that transition back to her original healthcare team, let her healthcare team know how she did, what your recommendations are, talk about those decreasing insulin resistance requirements, and you got to just see them very, very frequently. Let them know what your goals are now. These obstetric teams, we've got very narrowly focused goals. We got a lot of patients that we've got to deal with. It requires intensive resource funding. So I tend to try and transition my patients back to their original care team within a couple to 4 weeks afterwards, because I just got so many other patients I got to concentrate on. But good communication has got to occur between those patients that you've been caring for and their provider. And the really key link here is the contraception needs for those patients once that 4th trimester has been reached. Now, I know I've been talking forever. I know I went over into our question and answer session, but I'd like to open it up now and see what we got for questions.
Fantastic. We do have a couple, and I will just ask a few because we're getting really close to the hour here.
Yeah.
Dr. Berkowitz, I know you touched on this at the beginning, but a couple people had follow-up questions, but can you just explain in a little more detail why you prefer NPH versus long-acting insulin?
NPH is let's say you take it at bedtime. You're going to be able to get good glycemic control without a risk for hypoglycemia overnight. It's going to be out of your system by the time most people eat breakfast. So, most people are going to go to bed between 10 and midnight. Most people are going to get up between 6 and 8 and eat. And so that NPH really fills that niche very nicely. The long-acting insulins, as a baseline, are always going to be acting at the same level. So let's say you take your long-acting insulin at 11 p.m. when you go to bed. It's still going to be in your system at 11 a.m. But if you don't eat your morning snack or you have a light breakfast, that stuff is still there even if you haven't eaten appropriately, and you're more prone in pregnancy to get hypoglycemia. Likewise, because of that insulin resistance thing, that baseline level is not going to be enough to reach what your postprandial insulin requirements are going to be. So that's why I don't like the long-acting insulins, and that's why I prefer NPH. If a patient's doing well on her long-acting insulin and prefers it, okay, fine, but I just have had so few patients successfully transit that in the third trimester that I like to get them used to the regimen before that happens.
Perfect, thank you. Another question is, how often do you recommend checking A1C during pregnancy?
I actually love the meters where you can use the average glucose over the last 7, 14, or 30 days and just pop that into, Google any of the glucose things, and you can convert that average glucose into a hemoglobin A1C. So I don't think that you need to rely on a lab to do that if you've got a patient who is compliant with testing and can present you with her meter. I'm shooting for an average of 110, and over that 7, 14, or 30-day period, that translates, I think, to a hemoglobin A1C around 5.6 or 5.8.
Okay, great. And I think we'll make this the last question because we're right at the hour here. Does insulin action time decrease during pregnancy?
No, insulin is not renally cleared. Renal clearance of medications increases in pregnancy. Your plasma volume increases in pregnancy. But what happens is the kid is removing glucose from your system at a different rate. So your insulin actions are different, and you need more short-acting postprandial control with knowing the fact that that glucose is going to be removed from the system much more quickly than it would in a non-pregnant patient.
Wonderful. Thank you so much, Dr. Berkowitz, for being with us today and presenting on this really complicated topic that you did such a thorough job reviewing. And I just appreciate your time and your presentation. Thank you so much.
Thank you, guys. Thanks for listening.
And with that, I just want to remind everyone that you'll be getting that email in 1 hour's time, so at 2 p.m., explaining how to get your CEU certificate if we have record that you logged in. And with that, I will end our March 2017 CDAPP Sweet Success webinar. Thank you all for participating, and have a wonderful day.